Good morning, committee, again. Thank you, Madam Chair. House Bill 2223 relates to the practice of optometry. Section 1 amends KSA 16-1501, and it specifies the procedures that would and would not be included in the practice of optometry. Subsection A specifies what is included in the practice of optometry, with new language added in paragraphs 4 and 5. Paragraph 5 would permit additional procedures that are not prohibited in subsection B and are within the scope of a licensee's training and education pursuant to rules and regulations adopted by the Board of Optometry. And subsection B specifies the performance of the following procedures that lists those procedures that are not included in the performance of optometry. Section 2 amends KSA 65-1501A, and it removes the definitions for the terms topical pharmaceutical drugs as well as oral drugs. Section 3, which begins on page 4 of the bill, amends KSA 65-1505, and it adds a subsection G, which states that any licensee who is applying for credentialing by the Board of Optometry shall complete an application form, which would be furnished by the board, pay a fee, which would be determined by the board, and in an amount that would be necessary to reimburse the board for the cost of credentialing. Section 4 amends KSA 65-1509A to require the board establish credentialing requirements for a licensee to administer or perform the procedures in 65-1501A4, and those would be those new procedures, and those are on the bottom of page 1 of the bill. Section 5 amends KSA 65-1512 to name the provisions of Article 15 of Chapter 65 and amendments there to the optometry law. It's always sort of been referred to as the optometry law, but not specifically in the statutes. Section 6 amends KSA 65-1523, and it would allow the board to apply for injunctive relief for any person against any person to restrain violations of the optometry law. Section 7 amends KSA 74-1504 to provide that the Board of Optometry may maintain and make available to the public a directory including the names and addresses of all optometrists licensed by the board. This bill also repeals two sections, KSA 65-1514 and 1505. The bill would take effect on July 1st. There were no committee amendments or no House amendments, and the bill passed on a vote of 97-24. I'll be happy to answer questions as long as they don't involve having to pronounce half the names of these procedures.
Thank you, Jenna. Committee questions for Jenna? Seeing none, thank you very much. And committee members, our Senator Rose is in another committee, but he will be here and he's just going to be a little bit late. I have shared with the conferees, the proponents and opponents, because this is the only bill that we have today and there's a lot here to digest. We're going to begin with the oral proponents. There are 3 of you. There will be 12 minutes total. Each of you will be allotted 4 minutes. If one person doesn't take the full 4 minutes, somebody else can take a little bit longer. So we're running 2 clocks. One's 4 per person and the other is 12 total. The oral proponents, since there are only 2 of you, oral opponents, since there are only 2 of you, each of you will have 6 minutes with a total of 12, and we have 1 neutral opponent that will have 3 minutes. We will have questions and answers in between. Any questions about that? All right, we will begin with the first oral proponent, and that would be Todd Flesher.
Good morning, Chairman Gossage and members of the Senate Public Health and Welfare Committee. My name is Todd Flesher. I'm the Executive Director of the Kansas Optometric Association. I appreciate the opportunity to appear before you today in support of House Bill 2223. The reviser did a great job of explaining the bill, and like her, I'm not going to talk about some of the terms in there, but I want to give you a little bit of background about how we got here today. So about 6 years ago, we started this process to look at scope of practice in Kansas. The last significant change to scope of practice was actually in the late 90s. So as you can imagine, the technology, the treatment options, training and education has changed pretty dramatically since then. So our optometrists are telling us that they're frustrated that they're not able to take care of patients the way that they're trained, educated, and certified to be able to do. So about 6 years ago, we started this process and had some communications with the opponents to discuss about what our desires were to move the profession forward. This is something that we've had to do over the years. The KOA actually celebrates its 125th anniversary this year, and this is something we've had to do throughout our history. As technology has changed, we've had to come to the legislature and ask for changes to the Practice Act. So we met, we actually introduced the bill in 2020, ill-timed, obviously, based on what happened in the world in 2020, pulled that bill back, came back in 23, had additional conversations, introduced the bill in 24, and was heard here last year in this committee. We had additional conversations this winter, and then brought a bill forth earlier this year, and it moved out of the House last week, and as Jenna mentioned, 97 to 24. The reason for this bill is kind of twofold. First off, our doctors are frustrated they're not able to provide the level of care that they're trained to be able to do. That impacts patients because they're not able to deliver the care in their offices that they're trained to do. Our doctors have a wonderful working relationship with ophthalmologists and other healthcare providers in their community and throughout the state. But there's certain procedures that they're trained and educated to do, and they'd like to be able to offer that to their patients as a choice to be able to provide that for them. Secondly, in a time where our patient population in Kansas is aging, and the number of ophthalmologists is declining, we're also seeing where fewer and fewer students are choosing to come back to the state to practice because they can't practice to the extent of their education and training. Two of the written testimonies that you have in front of you are from students that are graduating in May. They're making determination about whether or not to come back to the state based on whether they can practice to the extent of their training. Recognizing that is a process to go through, but we're seeing more and more where students are choosing not to come here because of that. There's another example of a student who's a third-generation optometrist from Western Kansas who chose to practice in Colorado, where he's still close to family, but he can practice to the extent of his training. We have had multiple conversations. I do appreciate last week, Rochelle Columbo with the Kansas Medical Society approached us about some concerns about specific language in the bill that she felt gave the Board of Optometry too broad a control over the scope. We shared our concerns about why it was important, and we ultimately had a good conversation, and there is an amendment that when the bill is worked, that we would like to offer, that's a compromise agreement between the two sides to address some of their concerns but still provide the flexibility that we need. So we'll try to leave questions at the appropriate time and offer some of my time to the optometrist who can explain this a little bit better. Thank you.
Committee, next we have Shane, is it Canar? Welcome.
Thank you. Thank you for allowing me back this year to show my support for the modernization of the scope of practice of optometry in Kansas. My name is Dr. Shane Canar. I'm an optometrist in Southeast Kansas. I'm part of a multi-doctor, multi-location practice. We provide care for the community members in Southeast Kansas, focus in Pittsburgh, but also surrounding counties. And I think it's important as we begin this discussion, we talk about our average day and what occurs in our day. Yes, we provide refractive care for our patients, but each of our patients is also providing medical eye care, whether that involves a treatment, diagnosis, modification of treatment plan, or referral of these patients for ophthalmic conditions, as well as being closely tied to the medical community in our area to work with this underlying systemic conditions on our patients. In my practice, each provider has dedicated spots to take care of emergent patients that need to be seen that day and are referred over by primary care doctors and other healthcare entities. We also provide emergency room coverage for both hospitals in our county, as well as call coverage for the surrounding community or county's urgent cares. We are a vital member of our medical community, and we practice that way. As an optometrist, my education is not medical school, but my education is robust and vigorous. It includes a 4-year doctoral program that allows me to practice as an independent provider. We have over 10,000 hours of education in a variety of topics, including pharmacology, ocular disease, systemic disease, clinical procedures, and over 2,000 patient encounters by the time that we graduate. I bring that up because there's been somewhat of a misconception, if not indictment, of my profession on 2 items as this bill has been discussed. First of all, this bill does not move optometry into medical eye care. In fact, that's been happening for decades in our state for the betterment of our patients, and it's a system that works well. There's also been question about varying diagnosis and what would be labeled a misdiagnosis. I can tell you that routinely in my practice, we see patients where we offer a different diagnosis, which is correct. whether that come from other providers or ophthalmology. That's part of our healthcare system, and a variety of things lead to that. But I'm proud of the medical eye care that my profession provides in our state. And there is an access issue that exists in our state. And as we've had this discussion, I realize access can be looked at many different ways. At times, the opposition has said that most citizens of Kansas are within an hour of an ophthalmologist. And that is true in one way, but many times it's a clinic just like mine. That ophthalmologist is available one day a month to see patients in my community. That access is there, but it's very limited. In our situation, we live and work in that community. As I mentioned, we're a vital member of that community. Every primary care doctor has our phone number. Daily, we're asked questions, whether that be oversight on the management of patients, asked to be seen, a patient to be seen in our office. In times, access provides a real issue for us. We have to refer our patients out to other states or for 2-hour drives to receive care, times for procedures that we are trained, educated, and certified to deliver. There's some irony that exists because within 45 minutes, I can go to 2 states, whereas an optometrist, I could provide these procedures. Part of our goal from this is to allow, when an ophthalmologist is in our clinic, them to provide the care that only they are trained, educated, and certified to do. The last key topic, I think, is complications. And there's 2 things that we should discuss with complications. First, complication rate, and second, how those complications are handled. I will take that in reverse order. I will say that since I began practice in 2000, I have handled postoperative care from the day after a procedure for not only the procedures outlined in House Bill 2223, YAG capsulotomy, SLT, peripheral iridotomy, and lid lesion excision and removal, but also more complex and invasive procedures. We handle those patients medically if a complication occurs, or if necessary, we create a surgical referral for intervention for these patients. Many times that referral is to a subspecialist, not the provider who created the original referral. We are handling these complications and have been for decades in order to address some of our access issue. The next point is complication rate. There is no procedure and no provider that has a 0 complication rate. That's an unreasonable standard to hold any profession or provider to.
I'm so sorry. Your 4 minutes was up. If you would like to continue, we'll see how the other conferees do and then give you more time at the end. Okay, thank you. Next, we go virtually to Nathan Lightheiser. He's not on yet. If somebody, I'm sorry, stuck in the lobby. Don't know what that means, Nicholas. He has the link and he clicked on the link. Okay, then let's move on to William Wilk and then we'll come back when he's on. Okay, Nicholas, you let me know. Go ahead.
Good morning, Madam Chair, members of the committee. William Wilk, Senior Director of Government Affairs for the Kansas Chamber of Commerce. You've heard about what this bill does. It modifies the Scope of Practice Act for optometrists to allow them to perform certain procedures that they're learning in optometry school. Medical technological advancements have enhanced and continue to improve patient care and, most importantly, patient outcomes. Unfortunately, our state statutes for optometrists have not kept up to date with the advances of education and medical technology. The Kansas Chamber is expressing support of this bill from a workforce perspective of optometrists. We also believe this bill would increase the access to optometry treatment for Kansas, along with reducing wait times. 12 other states have passed this scope of practice bill to allow optometrists to perform these procedures. The Kansas Chamber will continue to advocate for reform of our healthcare statutes to keep pace with the advancements of medical technology while not sacrificing the safety of Kansans seeking and receiving treatment. Thank you for the opportunity to testify today, and I'm happy to answer questions at the appropriate time.
Thank you. Nicholas, any luck?
I think I am in. Dr. Nate Lightheiser here. Can you hear me?
We can hear you. Please go ahead.
All right. Hello, everybody. Madam Chairman, my name is Dr. Nate Lightheiser. I'm a faculty member, and I serve as the Dean of the Northeastern State University Oklahoma College of Optometry here in Tahlequah, Oklahoma. It's my pleasure to testify in support of the optometry bill today, the scope modernization bill. Like I said, I'm a faculty member and I serve as Dean of the College of Optometry. I have spent 16 years here at the Oklahoma College of Optometry. I was schooled in Oregon back in 2005 to 2009, and I did my residency in 2009, 2010 here at the College of Optometry in Oklahoma, where I was trained on laser procedures, eyelid injections, the procedures that are in this bill. Since I'm in academia and serve as the dean, I can comment and provide context to the training that currently happens in our optometry school, as well as all of the optometry schools, the 24 of them across the country. Our students are intensively trained on laser procedures, injections, eyelid procedures from year one of optometry school through their 4 years of optometry school. I actually just stepped out of what we call OD surgery clinic, optometry surgery clinic, where I have 3 students this morning, 2 residents, and I have a doctor, a colleague of mine filling in while I testify here, where we are doing laser procedures this morning, eyelid procedures, things like that. So the training is intensive. It involves classroom training where they're watching videos, getting intensive coursework, laboratory hands-on training. They are tested on both. And then they are obviously doing live procedures, as I just discussed, clinic going on right this morning. So that's the education and training that happens in optometry school. It is happening at all of the 24 optometry schools across the country, where they are taking laser courses and surgical procedures courses and injections courses, lecture, lab, and tested on those as well. You may ask, what then happens after graduation? What if a doctor graduated 20 years ago, 25 years ago, 30 years ago? As you all know, education and training happens beyond schooling, whether that's medical school, dental school, or optometry school. You are not limited to only doing what you were trained on during school. Education and training, technology evolves. I lead what's called our ophthalmic procedures course, otherwise known as the advanced procedures course, where we have traveled around the country and trained every doctor in Oklahoma, Kentucky, Louisiana, Arkansas, Colorado, South Dakota, the 12 states that currently authorize optometrists to do laser privileges, laser procedures that are in this bill here in Kansas. So there's a proven track record. There's been documented over 146,000 procedures that have been done by optometrists in the states that I just mentioned, with 2 documented complaints to state boards about those procedures. So 2 out of 146,000 shows a very strong proven track record for optometry doing these procedures. And they're already doing a variety of procedures, whether it's corneal foreign body removal, other procedures as well. They are already doing procedures.
Thank you, doctor. I'm so sorry. I'm afraid your time is up. We had a full 12 minutes of conferees. Thank you again for being with us, and if you're willing to stay on, there may be some questions for you. Committee questions for the proponents. Senator Clifford.
Yes, for Dr. Lightheiser, can you specify the number of procedures? There are 3 laser procedures being considered in this bill: YAG laser capsulotomy, peripheral iridotomy, and selective laser trabeculoplasty. How many of these on live patients are actually done by your students?
Quite a number of procedures are done by our students. It varies based on the student. I will tell you the overall answer is enough to be very comfortable with the procedures, whether it's capsulotomy, iridotomy, SLT, eyelid procedures. Some will do more than 10, some will do 3 or 4 or 5. I've got some with me today, one of our residents that's done more than 50. So it depends on their interest. As you know, some in ophthalmology, not everybody does the same number of procedures. The same is true here. We have, they get enough to be very, very comfortable. Again, somewhere between 3 and 4, up to more than 50, depending on the student, the day that they're in clinic, whether the patient shows up or not. So it's more than enough to be very comfortable doing these procedures.
Follow up, Madam Chair.
Yes.
How would a doctor in Kansas get this training? I know you've run courses here in the state, but it would be illegal to do laser on a live patient or lid surgery. How might that be done in training in a state like ours without laser legislation? Thank you.
So it depends on how what the law passes and how the law passes. In Oklahoma, I can comment on Oklahoma. You take the training course and
I'd like you to comment on a course you might and have run in Kansas. Thank you.
Say that again.
I'd
My
like you to
apologies.
comment on how would a Kansas optometrist in training be able to treat live patients without enabling legislation? Thank you. How do you train them?
We train them in the classroom through an intensive course, laboratory hands-on training with model eyes that were developed by ophthalmology, that ophthalmology uses to train. So we train them in the classroom, hands-on laboratory setting, and tested on that as well. Currently not allowed to do live patients in Kansas, so would not be able to do live training until the law passes.
Thank you. Thank you, Madam Chair.
Senator Thompson.
Thank you, Madam Chair. This would be for either Dr. I guess Canar, or Dr. Lightheiser. In section A1 or section 1A1, it strikes topical regarding the pharmaceutical drugs. So basically, it says it can prescribe or dispense pharmaceutical drugs for the purpose of diagnosing refractive muscular pathological conditions. I know a lot of times I'll go to my optometrist, I'll get something to deaden the eyes, but what pharmaceutical are we talking about with regard to those types of procedures?
For an extended period of time, we've been using oral pharmaceuticals, antibiotics, steroids, and different items. This law does move forward into injectable, where we could provide lid procedures and provide anesthesia for that area.
So that opens a pathway to doing some of these other procedures with the injectables, I'm guessing.
Yes, but it does not move us from, and I'd like to clarify that, it does not move us from topical to that level. It's oral medications and treatment have happened for an extended period.
Okay, thank you. Thank you, Madam Chair.
Senator Holscher.
Thank you, Madam Chair. Dr. Canar, maybe you can handle this one. I received an email over the weekend from an ophthalmologist indicating that a patient had come to him that had been told he had a sty from 3 different, I guess, optometrists, and then was referred to the ophthalmologist. And his concern that he brought up is, well, what if the optometrist had been allowed these different procedures? What the implications would have been, because this was a cancerous lesion. So can you help me feel a little better about that, or give me a little bit of background into understanding that?
We've had a very conservative profession, whether in Kansas or across our country, for an extended period of time. And you can see that with the slow, steady growth of these procedures being performed by optometrists in states where it's included. And I will say that I feel that most optometrists, if there's any question, will refer these patients out for a second opinion, and will continue to do that, or at a minimum request a biopsy on that lesion. Ideally, we will not be doing procedures where we have significant question. We would refer those. I can also say the same thing happens. We, in the last couple months, have been dealing with a patient who saw an ophthalmologist in Oklahoma, a 30-year-old with a complaint of distorted vision in an area, and had cataract surgery and YAG capsulotomy to no resolution. When they came back to our office, they'd moved away, they had a shallow retinal detachment. So while those instances can happen, they can happen across all professions, and we are judicious and conservative by nature.
Additional questions, committee? I have a question for you. The question was asked about how do you train an optometrist, let's say, that's going to be in Kansas. When they're and I'm assuming from what we heard that most optometrists are trained in Oklahoma?
It could be in a variety of, yes, Dr. Lightheiser is in charge of training many places across the country.
Okay. So if somebody wants to be licensed in Kansas and they're in training at this university in Oklahoma, but because Oklahoma allows these procedures, correct? Could they
Correct.
still do them while they're in training?
So the answer would be, if it's a student going through an externship, they would be allowed working under a doctor in Oklahoma to do it. It becomes a bit of a conundrum, and one that adds to the time it takes for us to begin to implement these. A provider such as myself, some of us will have dual licensure, where we can then learn in Oklahoma and provide these procedures. Others will have to slowly work, and we have to change our law first, and then they can begin to go through training and proctored cases as they undergo their training. But first, the law must be changed for it to occur in Kansas.
Right.
And I
Additional
could comment.
question?
I could
Yes.
comment on that as well. Accreditation standards as an accredited college of optometry, we can have students and residents, because they're in training during their formal optometry school or residency, do procedures under us. But we can't have doctors come in from Kansas, Colorado, North Dakota, or wherever, come in and do procedures because they're not enrolled in our program.
And that leads us to why we ask you to consider and pass House Bill 2223 this year. It is a procedure, or it is an implementation that takes time. And as we do see an aging population and a declining number of ophthalmologists, and really need for optometry to have ophthalmologists provide procedures they're uniquely trained to do, we need time to build for the future. And that's why the bill must first change, because of the way our statutes and laws are written.
Thank you very much. Seeing no other questions, thank you. In committee, we will now move to our opponent conferees, and we'll begin with Rochelle Columbo. You have 6 minutes. Or again, if you don't use it all, it goes to the other conferee.
Thank you. Good morning, Madam Chair, members of the committee. I'm Rochelle Columbo. I'm the Executive Director of the Kansas Medical Society. We represent physicians statewide of all specialties, so not just ophthalmologists, but other specialties as well. We appreciate the opportunity to be before you today in opposition to House Bill 2223. This bill is not necessary. There is not a shortage of care and not a lack of access. And even if there were, we don't believe it's in the best interest of patients to pit access against quality. Simply put, we have a philosophical disagreement with this bill. We believe that patients and outcomes show that patients are best served when there are consistent standards for training, education, and regulation for medical care and for surgical care. Optometrists are highly trained. They're valuable members of the care team, but they are not physicians. They do not go to medical school. They do not have 4-year residencies and required fellowships. During that time, physicians, no matter what their specialty, are under supervised training. They provide no independent care in the entire time of their medical school, residency, and fellowship. That does not happen until they have a full and unrestricted license. So that is a significantly different standard for the training of a physician or surgeon than an optometrist or non-physician. And we fundamentally believe patients are better served when those standards are consistent. You've heard from the proponent. I think Todd, Mr. Flesher did a wonderful job explaining some of the history of the conversations that have gone on in the last 6 years between the ophthalmologist and the optometrist, and the timeline, which was, of course, disrupted by COVID. But prior to that, the Kansas Medical Society has been involved in those incremental changes and agreements and efforts to allow their Practice Act to be modernized. In this instance, we do believe that the process would be better served, that the policy would be better if there were more time to further those discussions. But I did reach out to Todd last week when we realized this bill was moving rather swiftly, and ask if they would be open to an amendment about one of our most significant concerns, which is Section 1, Paragraph 5 of the bill. We have an amendment, and the Optometric Association has agreed to that amendment with an understanding that we all do want to make sure that patients are protected and that the professions recognize the distinctions between their different lanes. So to briefly describe the amendment, which I know the committee does not have, although I believe Jenna has copies, and I'd be happy for you all to have them at the appropriate time. The amendment is very simple. On paragraph 5, it adds in that the Board of Examiners, which oversees optometry, may approve and authorize new technologies pursuant to a recommendation by the Interprofessional Advisory Committee. Now, in the original bill, the Interprofessional Advisory Committee is stricken. That's 74-1505. That committee, I made a mistake in my email last night and said it was established in 1987. It was 1997, so I apologize. But it was established, and it was something that was negotiated between the professions of optometry and medicine to originally address glaucoma. But that's since been just really a settled issue, and so it doesn't meet anymore. The way that that interprofessional advisory committee is structured, it's under the Board of Examiners, which is the optometry board. It has 3 optometrists that are appointed by the KOA, and it has 3 physicians that are appointed by the KMS and KOAM, which is the Association of Osteopathic Medicine. It is overseen by an optometrist that is appointed by the Board of Examiners. So that board would meet and they would review new technologies. We believe this is really important because it brings in physicians and surgeons who have been trained in the way that I just described, who are licensed to practice the full scope of medicine and all procedures. And it allows them to provide input into those new technologies and how they could be applied. And if that committee comes to an agreement and makes a recommendation back to the Board of Examiners, then they can then authorize those new technologies also under rule and reg. We think that balances physician involvement and necessary legislative oversight. And so that's why we requested that amendment. We still are, philosophically believe this is not necessary, but if it is the will of this body and the legislature to advance this legislation, we would request your support for that agreed to amendment between the Optometric Association and the Medical Society. And there's a lot more I could say, but I'd like to yield my time, so I will stand for questions at the appropriate time.
Very good, thank you. And next we'll move to Brad Smoot. Welcome to committee.
Thank you, Madam Chair. Brad Smoot, Local Counsel, Legislative Counsel for the Kansas Society of Eye Surgeons and Physicians. We oppose HB 2223, and I'm going to approach it from a slightly different angle because I don't know anything about the procedures. Certainly others do. But what I have experience in, as many of you know, is reading legislation and reading statutes. And as I look at this bill, I see a lot of things that don't bring me a lot of confidence, and I suspect may not bring all of you the kind of confidence that you wish. One of the things that over the years I've noticed about lawmakers is they'd like to have confidence that they know what's in the bill and confidence that what they're doing protects their constituents and the people of Kansas. It's particularly true of this committee that deals with medically vulnerable patients. So with your permission, Madam Chair, I'd like to just recite a few of the things that jumped out at me. We heard again today that this bill is like 12 other states. Well, not exactly. Our research indicates that there's 4 other states that have a bill that goes as far as this one does. There may be features that are in here that are also in those other states, but we're not going to be number 13. We're going to be among maybe number 5. We may be among the most advanced in taking this leap in this direction. I would suggest that your staff could probably settle that disagreement about whether it's 12 or 4 better than anyone else. Again, suggesting that maybe we need a little more time to look into this to get it right. Secondly, if you look in the 4 corners of the bill, particularly section 1A5, it's open-ended. It says that the board, by rule and regulation, will look at technologies over time to decide what new procedures may be allowed. So while section 1A4 lays out what you can do, and B lays out what you can't do, this particular section opens the door for the board to decide just about everything new that's coming along in the future. They won't need to bring another bill before you in the future the way that's currently written. It relies on the education and training that you might receive in a college or school in another state, what you might learn over time. But it seems to be an unlimited grant. I would just remind everybody, if I might, that we spend a lot of time around this legislature worrying about the excesses of the executive agencies. You'll all remember that we had a constitutional amendment on the subject of legislative control over rules and regulations. We passed 2291 this year, the regulatory sandbox issue, same subject matter. How do we control rules and regulations by agencies? And we have an oversight committee that meets regularly and has for years to try to deal with regulations that are being promulgated by administrative agencies. It strikes me that the place to do the most effective control is right here. Put something in the bill that lays out the guidance for the agencies as to how far they can go, how far you want them to go, and not just carte blanche so that they can do pretty much whatever they want. I think that subsection 5 does precisely that. So I would encourage you to rein in the agency at the up front in the enabling statute rather than trying to claw back authority to the legislature at a later point. While we're talking about the board, let's talk a little bit about the structure of it. This bill was brought to you by the Optometric Association. That's who appoints, that's who nominates people for the optometric board. They're appointed by the governor, but they're nominated by this association. So what we have here is a situation in 4 of the 5 people on that board are nominated by the agency that brought you this legislation. They're in complete control of what is to be done by the board and also, indirectly, this advisory board that's being proposed in the amendment, and I'll discuss the amendment just briefly later. I would suggest that the amendment itself is probably a good idea. It's a step in the right direction. Our association was not involved in the crafting of it. We did get to see it this Sunday, and they voted against the amendment being adequate. We do think that it's, again, a step in the right direction. It shows that things can be compromised, can be worked out, as has been done in the past, as has been mentioned by the conferees on both sides. These types of issues often do better when they get resolved by bringing in all the players and sitting down and working these things out. But at this point, I don't think, unless it's been changed dramatically since the draft I saw, that we would support that as a solution or a compromise. We do think it's fine to add it to the bill if you decide to work it. Just on a couple of other odds and ends that just jumped out at me. If you look at section C, you'll see that the legislature saw fit to adopt a standard of care for glaucoma treatment. We haven't adopted a standard of care for any of these new procedures that are proposed in this bill. Why is that? Why is the standard of care appropriate in one case, not appropriate in another? I think it's something that the legislature may want to consider, and particularly this committee, in crafting the final version of it. I noticed something kind of odd in the section, I believe it's section 1A4, where it talks about removal of skin lesions. It doesn't say skin lesions on the eye. It's not limited to skin lesions around the eye. Might be the tip of your nose, might be your ear. According to this statute, it's wide open skin lesions. Again, a simple fix, but reason to look further at the details of this bill. I want all the folks in this room to be confident that what you do is what you really want to do, and to understand all the things that are the moving parts in this bill. And I know that you all want all Kansans to have faith that what we've done here, what you've done here, accomplishes that goal. To have that confidence, I think you probably will want to take a very serious look at how much is given away by the legislature in this bill and how many other things might be changed as well. With that, Madam Chair, I'm of course happy to stand for questions.
Thank you very much. And it is time for questions, and I just wanted to clarify for the committee, we will not be taking final action on this bill today. There's a lot for us to absorb, so we will do that tomorrow morning at the 8:30 meeting. So any questions for the opponents? Senator Thompson.
Thank you, Madam Chair. this might be for Rochelle or Brad. With regard to the 1A5 amendment, would that also apply to these procedures listed in 1A4? Would that be reviewed by this committee before any of those are approved, or would those just go into effect and then the committee would approve anything going forward? I'm just, obviously I haven't seen the language, so I'm just curious.
Yeah, thank you. Thank you, Madam Chair. If it would be appropriate, it would be fine. I know Jenna has the copies and they could be handed out so that people could look at them and review them, and that might help. No, is the short answer. This would only apply to new technologies and procedures that are not included or expressly prohibited in this bill. So that section 5 really, or that paragraph 5, I would agree with the other conferee. It is wide open as is currently written. It says any new technologies may be really independently approved unless they are expressly prohibited. They could be approved by the board without any other step than administrative rules and regulations. So this would add in that it would go through the interprofessional council, but it doesn't address the procedures that are approved in this bill, and it doesn't allow for the ones that are expressly prohibited. Does that answer the question?
Yes.
Okay.
Yeah, yes, absolutely. Thank you. Thank you, Madam Chair.
Senator Holscher.
Thank you, Madam Chair. Rochelle, this question's probably for you. I mean, I understand there's differences in the background and training, but when we're talking about some of these more minor procedures, is it not possible that both optometrists and ophthalmologists are qualified to perform them?
I appreciate that question as well. And I guess I would answer two different things. I think things get characterized as minor when they can be performed by any number of providers, but that doesn't mean that they're always appropriate. And it doesn't mean that they can't have complications that would not require in both, either prior to that procedure or after, if something were to go poorly, a more comprehensive medical education and training. And so I would answer, I think that's a little bit, pardon the pun, the wrong lens to look it through. And secondly, that that's the purpose of not having independent medical and surgical care that doesn't allow for someone who has that comprehensive training to be either in collaboration with or in supervision of those procedures. So yes, I believe that there are a number of procedures that today that are performed by non-surgeons. The question that you are asking is, should they be independently performed without any physician connection that can then restore or direct that care before or after? And that's where we believe there is a serious concern, because this would allow for that independent surgical procedure by a non-physician.
Senator Clifford.
Thank you, Madam Chair. You've worked out this amendment with the other side. Still, I know you voiced a philosophical objection to the bill. Are you against this legislation the way it is in the bill?
Yes, we are opposed to this legislation. Like I said, we don't believe it's necessary or in the best interest of patients, and we don't believe that the bill should move forward. However, if it is to move forward, we believe it would provide more patient protection by adding this amendment. Is it enough? No, but we believe it's a positive step in the right direction. But no, we oppose the bill overall.
Thank you. Thank you, Madam Chair.
Additional questions, committee? Senator Thompson.
Thank you, Rochelle. Might as well stay up there. I'm looking at this section 1A4. It's got the listing of procedures and things. There's one I see, expression of conjunctival follicles, which I think they may do already with like styes or things of that nature. So it looks like, or is that a list of things they're doing already, or a list of things that we're proposing to do going forward, opening up the opportunity to do that? Because some of this looks like they might already be being done, but I'm not sure.
I think it would be appropriate to ask the optometrist, but there are probably optometrists in certain settings that are doing that. They may be working at an eye surgeon's office. And so again, there's that connection with a physician, but this is allowing independent authority for all of these listed procedures.
That's a good question, because I know I go to an eye clinic, but they've got ophthalmologists and optometrists together, and I didn't know if the optometrist was performing that and under the auspices of working with the ophthalmologist, so.
They would certainly not be allowed to do any of the things in that list independently now. So that's new authority. So the only way it would happen now is if they have a physician relationship.
Okay, thanks, Madam Chair.
Quick question from Senator Clifford.
Just a point of order that we physicians have delegatory authority. I think that's what you're indicating. And we can delegate things to people under our direct supervision. Thank you, Madam Chair.
Correct.
Thank you very much. And committee, we will now move to the neutral testimony. Susan Guile, please correct me when you come to the mic.
Is it on? Okay. Good morning. Good morning, Chairwoman Gossage and committee members. My name is Susan Guile. I am the Executive Director of the Kansas State Board of Healing Arts. Thank you for allowing me to speak today. You have my written testimony. I'm not going to go through all of that. We've heard wonderful information from all of our other conferees today. So I just want to make a few points. The board's mission is public protection. And so everything I want to talk about today, I want to begin from that perspective. The regulation of medicine and surgery is the board's mission, and we take that very seriously. KSA 652801 states, recognizing that the practice of the healing arts is a privilege granted by legislative authority and is not a natural right of individuals. It is deemed necessary as a matter of policy in the interest of public health, safety, and welfare to provide laws and provisions covering the granting of that privilege and its subsequent use, control, and regulation to the end that the public shall be properly protected against unprofessional, improper, unauthorized, and unqualified practice of the healing arts from the unprofessional conduct of persons licensed to practice under this act. I'm certainly not trying to say that the optometrists are unqualified. They're very, very well-qualified profession. They are not qualified to practice medicine and surgery by the means of their education and training. I outlined in my testimony the differences in the education and training of an optometrist versus an ophthalmologist, and I think that's very important for us to keep in mind. One of the conferees, and I'm sorry I don't remember his name, he was virtual, he said in his own testimony that the students in his practice are doing 3 to 5 of these procedures. I don't know the exact number, but those in the ophthalmology school are doing hundreds of these procedures before they finish their residencies and subsequent fellowships. And they're doing them on live patients. There's a vast, I am not a physician, but there's a vast difference in doing a procedure on a model versus a live patient. And they're just not simply two sides of the same coin. They're just not. They're vastly different things. The MD ophthalmologists are trained surgeons, and as Ms. Columbo said, they're ready to step in the event that something goes wrong. And again, our optometrist talked about that of 146,000 procedures, there's only been 2 complaints to a state medical board. That is not a benchmark. Many people don't complain to a state medical board. There's actually been studies about why people don't complain. There's many reasons. Many people don't know that there is a state medical board. They don't know that they have that option. So again, by passing this bill, you're allowing, the legislature is allowing non-medical professionals the ability to practice medicine and surgery. And so thank you for your time. I'll stand for questions at the appropriate time.
Thank you. Committee questions for Ms. Guile. Senator Petty.
Thank you, Madam Chair, and thank you for being here. I would say I believe your testimony is neutral, not neutral, but an opponent. But just as a clarification, the doctor who testified online, he did mention that some students, but he also mentioned other students had 50 or more. So that's a poor presentation on what he said, and I don't think it's fair to repeat those kinds of things, taking them out of context.
I appreciate that. Thank you.
Additional questions, committee? Seeing none, thank you so much for coming.
Thank you.
Committee, you do have a copy of the amendment, and that takes some time today to review, reach out to the opponents, and we will take final action tomorrow morning at 8:30. We are adjourned.